With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi everyone and welcome to the May 2019 edition of PRS Journal Club podcast. I'm Raj Parikh, PRS Resident Ambassador from Washington University in St. Louis, and I'm joined by my co-resident ambassadors, Lily Mundy from Duke University and Kyle Sanniec from UT Southwestern. Today we have the honor of being joined by Dr. Terry Myckatyn, Professor of Plastic Surgery and Director of Cosmetic Surgery and Breast Microsurgery at Washington University School of Medicine in St. Louis. Thank you so much, Dr. Myckatyn, for joining us for this PRS Journal Club podcast.
My pleasure. It's great to be here. Thank you.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we will be discussing is Breast Cancer Knowledge and Decisions Made for Contralateral Prophylactic Mastectomy, a survey of surgeons and women in the general population. This article is from Dr. Momoh and his group at the University of Michigan in Ann Arbor. And in this study, the authors conducted a cross-sectional study of 3 different cohorts: lay women in the general population, breast surgeons, and plastic surgeons. They recruited lay women using the Amazon Mechanical Turk crowdsourcing program, and then breast and plastic surgeons were sent electronic surveys, and these were identified from 9 different states. They collected demographic and contralateral prophylactic mastectomy specific information and then evaluated decisions and knowledge for the lay women. What the survey found was that there were 1,333 lay women, 198 plastic surgeons, and 142 breast surgeons who were ultimately analyzed and comprised the study population. They found that a significantly greater proportion of lay women in the general population favored contralateral prophylactic mastectomy, around 2/3 or 67% relative to plastic surgeons, which was only 50%, and breast surgeons, which was about 1/4 or 26%. And this was statistically significant. When they analyzed knowledge, they found that nearly 80% of lay women had a low level of breast cancer knowledge, and lay women with higher levels of breast cancer knowledge had a much lower odds of choosing contralateral prophylactic mastectomy, an odds ratio of 0.37. They also found that breast surgeons who chose contralateral prophylactic mastectomy were younger and female compared to breast surgeons who preferred not to have contralateral prophylactic mastectomy. Ultimately, the authors conclude that fewer women are likely to make decisions in favor of contralateral prophylactic mastectomy if they have better breast cancer specific knowledge and education. They explain and theorize that this is likely due to a knowledge gap, and that would explain the lower rates in which surgeons choose contralateral prophylactic mastectomy for themselves or their loved ones. However, acknowledging that some surgeons who are young and female still prefer contralateral prophylactic mastectomy. Ultimately, they conclude that improving patient education on surgical options for breast cancer treatment is critical, and that well-informed decisions should be the goal. I thought this was a very interesting study that addresses an important area in plastic surgery and in breast cancer treatment. The rates of contralateral prophylactic mastectomy are obviously increasing dramatically in the last 10 years, and there's growing concern from some breast surgeons that this is not an appropriate use of resources and that you're also subjecting women to an unnecessary risk without much benefit. So this was a great study to really look at some of the motivating factors and to kind of understand why certain women, especially lay women in the population, what their knowledge of breast cancer is, and then what their thoughts are on contralateral prophylactic mastectomy. With that said, I wanted to jump right in and get Dr. Myckatyn's thoughts on what you thought of this study and how it was designed using crowdsourcing and comparing lay women to breast and plastic surgeons as kind of the comparison, and just the assumption being that breast and plastic surgeons are obviously more knowledgeable in general on breast cancer and breast cancer treatment than lay women are.
In reading this, as I was going through it, I did wonder to myself, using this Amazon Mechanical Turk, whether they were selecting for a population of women that was going to be younger and more tech savvy. And then as I sort of continued to read through, in fact, that was the case. They said that only 32% of the women were older than 40 years of age. So right out of the gate, I did wonder a little bit about the generalizability of these findings relative to the typical breast cancer population. That said, I do think it's also a very clever way of leveraging this new Amazon Mechanical Turk technology for plastic surgery research. And so from that perspective, I certainly give Dr. Momoh and his group kudos for that. I did wonder, reading this article as well. They talk a fair amount about the knowledge gap, and it sounded like, if this knowledge gap was improved, that more women would choose not to have contralateral prophylactic mastectomy. But it seemed to me that this was very much focused on survival. So the knowledge gap based on survival rates. But as we all know, the decision to have breast reconstruction goes well beyond that. Also, I did wonder a little bit about just the simple fact that as plastic surgeons, we're in a very powerful position, so we can skew the type of knowledge that we present to our patients. We can focus more on survival rates, which of course are extremely important, but we can focus on that, or we can focus on symmetry or complication rates. So depending on the type of information that we impart to our patients, we are in this really sort of powerful position to influence how they make their decisions.
Thank you. Yes, I think that's an excellent point. I think really one of the more interesting findings in the study for me was that breast surgeons who were young and female were more likely to opt for contralateral prophylactic mastectomy, which somewhat reflects the laywoman in the population, as you said, of people that are more tech savvy and that are younger in general, and that maybe are not as knowledgeable about breast cancer decisions in specific, but are more active looking for resources through different variety online. One other thing that I thought was very interesting was that breast surgeons and reconstructive surgeons often attributed different levels of importance to some of the motivators for contralateral prophylactic mastectomy. And then symmetry and freedom from surveillance were much more important to plastic surgeons compared to breast surgeons, who found that those factors didn't really matter. So what do you make of that finding, and why is there still this persistent gap between what breast surgeons and reconstructive surgeons think motivates patients, and then how do we kind of bridge that gap going forward?
I too found that to be fascinating from the study, that they were able to sort of tease that out. So I think, for one, the surgical oncologists, we go into plastic surgery, we go into surgical oncology because that's what we're passionate about, that's what we're interested in. So I think at some level it's a little bit of a self-fulfilling prophecy that as plastic surgeons, we value symmetry, we value the types of procedures and the value that our reconstruction can bring to our patients. And so, whereas a surgical oncologist probably doesn't have that same level of passion going in. So I think just by the nature of what they chose to do, you can sort of tell perhaps what they prioritize. I think beyond that, and this point was made in the article, was that the younger female surgical oncologists did favor contralateral prophylactic mastectomy. And then that sort of begs the question as to why these differences existed. In other words, do young female surgical oncologists have different priorities, and why would that be? And so, sort of thinking about that a little bit, the reality is, I think that there are more young female surgical oncologists coming into the specialty at this point in time. And those surgical oncologists trained at a time when we're now starting to value reconstruction more. So after the legislations in 1997, and so they're training during that time when you see the rise in reconstruction overall, and training during a time when you see an increase in nipple-sparing mastectomy. Whereas the older male surgical oncologists trained more so at a time when reconstruction wasn't being valued as much. It wasn't being offered as much. So I think this may be somewhat, at least, reflective of the training that the various cohorts of surgical oncologists underwent in their past.
This is Lily here. Dr. Myckatyn, I think you bring up a really great point that's especially relevant to my institution at Duke. Just in the past couple of years, the surgical oncologists, the breast oncologists that have been hired have all been females who trained at, big cancer institutions where reconstruction is obviously very prevalent and very well respected and sort of a very integrated part in the care of those patients there. And so I can, easily see how that in and of itself just can sort of explain that trend. One sort of limitation just to bring up for this article, something to consider, is that with the surgeons, they had only, I believe, an 8% response rate, which is obviously really low. They kind of attributed this to maybe a little unclear on what specialty or subspecialty some of the surgeons that were surveyed were, and so maybe this isn't a true 8% response rate out of breast reconstructive surgeons, but maybe it's much higher, but they weren't able to provide that data. So I do think some of their findings we should just take with a grain of salt, but obviously, part of the role of this paper was for us to have this conversation, which we are, which is great.
I totally agree. And the other thing that's happened too, I think, is that breast surgical oncology has been, I think, recognized as a surgical subspecialty, a defined surgical subspecialty, more now than it has in past decades. And so I think as a result of that, there is more attention paid to the various aspects of that, as we sort of talked about the reconstructions, nipple sparing approach, other approaches to try to minimize incisions, improve aesthetic outcomes, oncoplastics, all those things. And I think as surgical oncology develops as a subspecialty, I think that they are taking better care of patients, just like we are in our plastic and reconstructive surgery.
Thanks, Dr. Myckatyn. That's a great point. I thought something else that you had mentioned was just the interest in breast reconstruction was around 83% in laywomen, 92% in breast surgeons, and then obviously 99% in reconstructive surgeons or plastic surgeons, which makes sense. But the interesting fact was just that 83% of these over 1,300 laywomen who were surveyed had an interest in breast reconstruction. We know, depending on which study you look at, that it's probably around 50 to 60% of patients who actually get reconstruction who've had a mastectomy. So I thought that that was really interesting to see, like a very up-to-date number on how many patients actually start out at least interested in reconstruction. And obviously these are laywomen, not patients with breast cancer, but just kind of a representation of the general population. That to me was very fascinating, and obviously an area that we can improve on how many patients are getting reconstruction compared to how many start out interested. And one of the other things was also just kind of a big picture question, and I talked about this a little bit in your discussion, but didn't really expand on it. So I wanted to get your thoughts, Dr. Myckatyn, and you as well, Lily and Kyle, is there actually that much detriment to contralateral prophylactic mastectomy? Because there have been studies that show patients have higher overall satisfaction, they have a better psychological outlook compared to patients who just have unilateral mastectomy, and especially when you combined bilateral mastectomy with reconstruction, and then one of those sides is contralateral prophylactic, obviously, those patients are happy in general, and they have a good quality of life. And yes, you're subjecting them to a slightly higher complication rate, but I guess the question is that trade-off worth it? And is there actually so much desire to curtail contralateral prophylactic mastectomy going forward, or is this something that is actually a positive trend?
So I'm just going to quickly touch base on that, the fact that 83% of the lay women in this study were at least interested in breast reconstruction. I also agree with you that that's fascinating. And to me, that sort of represents the denominator of women that would consider it. And then from there, we look at barriers as to why perhaps we get from 83% down to whatever the current reconstruction rates are, 50, 60%, or probably, unfortunately, a little less. And so, at that point, then it becomes reasons due to comorbidities or access or travel distance or not being offered by the surgical oncologist or by the plastic surgeon. So I agree with you. It shows us that we are doing better, that there is still substantial interest in women who elect to potentially undergo mastectomy, but there is definitely room for improvement still. With regard to the detriment of contralateral prophylactic mastectomy, I would address it first by saying that in our practice, over 70% of the patients I see get contralateral prophylactic mastectomy. And we've published stuff in nipple sparing mastectomy and deep flaps and the like, and just kind of looking over our own data, it's over 70% in those studies. And so I think it's a very personalized decision-making process. So I think that, and this may sound cliche, but it's entirely true. So, for women that are healthy, that are either prophylactic or early stage cancer, that can have a nipple sparing mastectomy. I mean, the reality is with some of the different techniques that have developed, we can offer these patients an excellent aesthetic outcome with a very low complication rate in 1 or 2 operations. And I think for those patients, they are very happy. I completely agree with you. The problem is trying to generalize this to the entire cohort of women. And so a woman who is tautic, or a woman who doesn't actually care that much what her aesthetic outcome is, or a woman that's radiated. I mean, all these women are going to have a very different set of priorities themselves. And frankly, even as a reconstructive surgeon, I'm going to have sort of a different game plan on how to address all of them. So I think a woman who has low aesthetic demands, potentially a woman who has greater comorbidity, I'm going to be, I think, less inclined to push for contralateral prophylactic mastectomy. And I shouldn't probably use the word push, but I'd be more receptive to them wanting to have contralateral prophylactic mastectomy in a patient that I think is going to do well with it. I think you have to look at risk prediction. I think you have to look at their comorbidities and make this sort of balance of quantitative data with patient desires and sort of this more qualitative, psychological driven decision-making process for these women.
Dr. Myckatyn, it's Kyle here. I agree with a lot of the thoughts. The question I had, and we've had issues in the past at Parkland specifically, is a lot of times, I don't know what you would call it with the breast surgeons, but the thought is that, treat the cancer, get it done, get them healed, and then come back if they want a prophylactic contralateral mastectomy. So, we've had a hard time originally breaking into that kind of pattern, trying to doing it at the same time or put expanders in the same time. And, the breast surgeon has the patient there and they're telling them over and over again kind of this philosophy. So have you had any issues with trying to get buy-in from the breast surgeons?
Not the ones that I work with, frankly. I guess I'm blessed with the surgical oncologists that I work with are excellent, and they sort of belong to that young woman cohort that we were discussing earlier. So they're entirely on board. I do think, though, as things get busy in a cancer center and you're trying to minimize the amount of time between diagnosis and cancer resection, that I can certainly see instances either for, it sort of sounds terrible, but the reality is just trying to get through and get these patients treated, or because potentially they have substantial comorbidities and certainly delayed reconstruction in some of these patients. There's good evidence to show that that is one way to reduce complications. Sort of this delayed immediate reconstruction is an appropriate avenue. But I have not come up against surgical oncologists that are not receptive to trying to work together to get it all done at once.
Lily, did you have any thoughts?
Yeah, so we actually at Duke have had some research come out of our institution to not support contralateral prophylactic mastectomy for the perspective of quality of life or satisfaction. Some of the research that has come out a lot has been driven by our breast surgeons, has sort of shown that women who had contralateral prophylactic mastectomy versus those who didn't ultimately didn't, have outcomes that were statistically different from each other. So I don't think we do 70% contralateral prophylactic mastectomy. I don't think anyone at our institution would really push a woman not to have it if that's something that she felt really strongly about. But I don't think our breast surgeons are really pushing women to go down this path, and in some ways may just try to give them a lot of education about it. And I don't want to say push them against it, but just kind of, providing them with all of the risk, pros and cons, and trying to provide a lot of education so they make an educated decision. So I'm curious, Dr. Myckatyn, would you, if you had a patient that came to you and they said, this has been what's offered to me, and I don't have any genetic risk factors, I'm not BRCA, or I don't have an otherwise need to have the contralateral side done, but I don't know what I should do, what do you think? If they're really asking for you to sort of push them in one direction or the other, do you have sort of a go-to and what you recommend to that patient?
So this comes up a lot. And what I would say is that as a plastic surgeon, I ultimately don't think it's our decision. And so I always ultimately defer to the surgical oncologist. So I say that up front. And then the next thing that I say is I do tell them that their survival rates are not statistically significantly improved if they have contralateral prophylactic mastectomy. We go through that. We talk about the fact that even if you have a mastectomy, you can still develop breast cancer on the ipsilateral side as well. So we go through that, and then I try to personalize it for that individual. So if that individual, I think, is going to have a much better symmetric result with bilateral mastectomy and bilateral reconstruction versus doing a balancing procedure, I tell them that. And I tell them that, I don't think that that's necessarily why you should make the decision, but when it comes to symmetry, this is, I think, what your outcome will be. And I described the two outcomes that I think she would get, whether it's uni versus bilateral. But then I also talk to them about risk. If there is somebody with low risk, we have a risk prediction model that we use as well. So I give them that, and I always tell them that if they have a bilateral reconstruction, they are having more surgery, so they will absolutely increase their risk. So I try to really keep it fact-based and then allow them to make the decision based off of that. But I do think that when we talk about providing information and knowledge, it's more than just survival rates.
Do you find that you're having different conversations with women about symmetry who come into it knowing they want either an implant-based or an autologous reconstruction?
Yeah, I think to some extent that's true. I think the other area where we have discussions related to symmetry are patients who are radiated on one side versus not on another side, but are having the same procedure on both sides. That conversation, at least in my practice, comes up more. In terms of implant-based versus flat-based reconstruction, I think whether you have bilateral flaps or you have bilateral implants in the non-radiated breast, I think you will have better symmetry either way than if you have a unilateral flap versus unilateral implant. I do think for most women, a unilateral flap will give better symmetry than a unilateral implant, though. So from that perspective, yeah, I would agree with you.
Thanks, Dr. Myckatyn and Lily. I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune into the other 2 articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not already done so. This is where our monthly journal club takes place. And once again, thank you so much, Dr. Myckatyn, for joining us and for this excellent discussion.
Thank you.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.